Good morning, students. I am recording your supplementary voiceover PowerPoints per the class request. We're going to cover chapter 9, 10, 11, and 12 today, but I will separate them into individual video links for you. I just ask that you bear with me. I do have a little bit of a cold today, so it may sound congested. If there's something you don't understand because of the way that I'm speaking, please don't hesitate to reach out to me and let me know that you missed something and maybe what slide we were on or what we were talking about around that time. Okay, so let us dig in. So in class on week 2, we found out, or during week 2, we found out that there are many different types of antibiotics. We learned about sulfonamides, which inhibit the activity of folic acid. We learned about antibacterial drugs that interfere with the synthesis of the wall for those bacterial cells. And then we also learned about antibacterial drugs that interfere with the synthesis of proteins, which prevents reproduction of those bacteria cells. And we really dug into the different types of drugs, things we need to know as far as patient teaching, adverse effects with those drugs. And I think we did a really knockout job of getting those clarified and explained, but we didn't talk so much about things like fluoroquinolones, and then we didn't move into the antiretroviral and antitubercular drugs. So we'll talk about that today. Antibacterial drugs that interfere with DNA and RNA synthesis. So this is kind of straightforward, right? It tells you exactly what their mechanism of action is. Some good examples of the first class of drugs we're going to talk about, fluoroquinolones, include ciprofloxacin, which is Cipro, super common for urologists, Gimafloxacin, Levofloxacin, also a common urologist med, moxifloxacin, which is often an eye drop, and ofloxacin. So these all end in a sin, and most of them fluoxacin, and they are fluoroquinolones. Many fluoroquinolones that you take by mouth are actually extended release drugs. So what does extended release mean? I'll give you a second to think about it. Well, when we're administering those drugs, you have to realize that they are being administered or they're being distributed and metabolized over time, right? And that's because they're being absorbed over time because of the way that they are provided to us, right? How our supply is. And we don't want to mess up that absorption process. Otherwise, we're going to disrupt the other parts of the pharmacokinetic process. So we're going to mess up the distribution and the metabolism of the drug as well. So we don't want to crush or have our patient chew them or break any extended release medication. That's just generally speaking. But like I said, many fluoroquinolones, especially like Levaquin and Cipro, come in extended release form. So we want to be aware of that. Okay, moving into more mechanism of action. Okay, so these are bactericidal drugs because they're interfering with the actual DNA of the bacteria. They're not able to reproduce and they die, right? They die because they can't do their basic metabolic functions to stay alive. We use fluoroquinolones for many different things. We use fluoroquinolones to treat both gram-positive and gram-negative microorganisms. Wow, that's exciting because before, remember when we were talking about aminoglycosides, they only treated really our gram-negative. And then we talked about like vancomycin treats our gram-positive, like MRSA. So just depending on what organism, we had to pick the correct antibiotic. Here, we can cover a whole host of organisms, gram-positive and gram-negative bacteria that may be causing things like lower respiratory infections like pneumonia or really bad bronchitis, bone and joint infections, oh my goodness, like osteomyelitis or bursitis, urinary tract infections, and that's where I talked about the urologist really liking these, and then infections of the skin. So like staph infections of the skin, sometimes we'll use this for, it's a little less often than our other medications. They're more first line. And then STDs can use fluoroquinolones as well. Okay, so we've talked about action and we've talked about uses. Let's talk about adverse reactions. So what happens when we give fluoroquinolones? Well, there's a lot of things about fluoroquinolones that make them special. Well, let's first talk about those common ones that don't. Common medication, antibiotic side effects, nausea, diarrhea, abdominal pain, right? We see that a lot. Additionally, these can cause headache and dizziness in patients. We see these in people that take fluoroquinolones pretty commonly. And then I told you there were some more specific things. And if you're looking at the serious adverse effects list, you're probably saying, which one of these is new? Because we've seen this with all kinds of antibiotics. Well, it's one that's not on the slide, actually, a couple that aren't on the slide. The first is Achilles tendon rupture. Fluoroquinolones are really hard on our tendons and connective structures. So we see Achilles tendon rupture as an adverse effect and complication of fluoroquinolone administration. We also see that fluoroquinolones can sometimes cause neural effects like seizures. Okay. They can predispose our patient to seizure. And then those other more common or the ones that we've seen before, serious adverse effects, photosensitivity. Remember, this is skin sensitivity to light, hypersensitivity, which is allergy. I tried to pause like Dora the Explorer to give you guys a second to remember that one. Bacterial and fungal superinfections. Fungal superinfection example, yeast, right? Candida. And then pseudomembranous colitis. What bacteria causes pseudomembranous colitis? That's C. diff. Great job. Okay, so we've talked about action, uses, and adverse reactions. Let's talk about contraindications. So people who shouldn't take this drug, if they have a history of allergy, probably shouldn't take the drug, right? If they're younger than 18 years old, we actually don't want them to take this drug either, because it is a drug that has some pretty serious adverse effects. So we really want to be careful with who we give it to. This one is not safe during pregnancy, and it's not safe for people who are not able to follow those special photosensitivity precautions, like wearing sunscreen and wearing protective clothing and a hat when you go outside and decreasing outdoor activities. Fluoroquinolones are used cautiously in patients that have diabetes, patients that have issues with their kidneys, patients who already have a history of seizures, are elderly, and those on dialysis. Okay. Interactions, drugs we don't want to give this with, or we want to be aware of the interaction and have physician approval if we're going to give it. Theophylline increases the serum level of the drug. Cimetidine, which is Tagamet, it can be used for GI things. It can also be used to stimulate the immune system. It really hampers the elimination of the antibiotic. So we're holding on to the fluoroquinolone longer than we want to. Oral anticoagulants. So if we're taking blood thinners with fluoroquinolones, we actually have that increased risk of bleeding. And then antacids, iron, salts, or zinc. Just like with some of our other medications like tetracyclines, we don't want to take those calcium-containing medications or iron because they interfere with antibiotic absorption. And then NSAIDs put us at an increased risk of seizure. So taking fluoroquinolones and NSAIDs is really where we run that risk of seizure. I told you that was a little bit special for this drug. Okay, before we move into my true false questions, I want to just throw out there that since we know calcium containing medications can decrease antibiotic absorption, what food should we avoid? And the correct answer there is your dairy products, right? You want to avoid those dairy products, just like with your tetracyclines, with fluoroquinolones. Additionally, you really want to be careful with how fast this IV med is going, if it's an IV form. I know that typically as LPNs, we're not starting this or pushing this. Obviously, they do a lot of weird IV push meds now for antibiotics, where instead of putting them in bags of carrying fluid. But we want to make sure that the rate is appropriate, because if we're going over like 60 milliliters an hour, it can cause a lot of irritation to the skin. So we want to be inspecting that IV site for redness, irritation, and burning and pain. Okay. Here are your true false questions, and I'll pause to give you some time to think about it. Fluoroquinolones are the primary class of bactericidal drugs that affect the bacterial cell by interfering with the synthesis of RNA. True or false? And that is false. Remember, these interfere with the synthesis of DNA, and they treat both gram-negative and gram-positive microorganisms. That not only makes them special, but that's really important for you to know. Okay, we're going to move into the nursing process before we come back and do another question. Okay, so I told you that your book really likes to break down each of these drug classes and tell you what your job is as the nurse in each phase of the nursing process. So ADPI, let's think about it. Let's start with A, assessment. What are you going to be doing before you give a fluoroquinolone? Well, givens, right? Vital signs, get a list of their symptoms they're currently experiencing, and get a history of their drug allergies. I probably already also would like to have like their medical history, family history, etc. Right? I'm going to get that whole history. And then I'm also going to do my physical assessment. So make sure that my patient is, otherwise healthy and doesn't have any like existing issues with their tendons or diabetes or seizures, all of those kind of things. Then my primary healthcare provider may want to order a culture and sensitivity before my first dose of my antibiotic. Remember, cultures tell us what bacteria, and sensitivity tells us what antibiotic works best for that bacteria. We want to make sure that fluoroquinolone is the best medicine for the bacteria at hand. You always want to do that before you give the antibiotic. Otherwise, you might kill the bacteria in the blood sample, and we're not able to tell which one it is. And then we might want to do some renal and hepatic function tests because these medications, like most antibiotics, can be a little hard on the kidneys and the liver. A CBC and a urinalysis may help as well, just to kind of let us know the overall status of our body and if we have any existing like anemias or leukopenias or thrombocytopenias. Okay. Ongoing assessment. So the ongoing assessment is after I've given it, what do I need to continue to do? So obviously we need to be checking those vital signs. We also need to be looking for adverse reaction. And if my patient does develop an adverse reaction to our fluoroquinolone, I need to let the doctor know as soon as I possibly can that, hey, my patient is having, a difficult time with this medication and they're experiencing this bad side effect. So we need to do something about it. Okay. So nursing diagnosis. So we're moving into D of the ADPI acronym. Diagnosis. So we don't assign these as LPNs. RNs will assign these for us, but it's good for us to know what might be some appropriate diagnoses associated with patients taking fluoroquinolones. Risk for impaired comfort related to their fever. So if they have, an infection, they've got a fever, they might not be comfortable. Risk for impaired skin integrity. We know that there's a risk of photosensitivity. So with that, they might develop a rash or, some bumps, maybe even a burn. So we want to be very, very careful with protecting their skin. Acute pain. There may be some tissue injury during drug therapy. So we talked about how this is really, really irritating to the skin and to the veins. So there might be some tissue injury while we're giving this medication. Additionally, we know tendons can become affected. So we might develop like a tendinitis or a rupture, which would be painful. And then diarrhea, super infection. So let's think C. diff, right? So pseudomembranous colitis, that's a super infection that's bacterial in nature. That might happen while we're on this antibiotic. It is one of those adverse reactions. We need to be looking for that. P, planning. The expected outcomes are, first of all, we respond to the therapy. Great. Second of all, we manage any drug reactions that pop up. Okay, we're not going to say that there won't be any, right? Because we don't know. We have no control over that. But if some pop up, we're managing them. The patient has decreased anxiety and the patient understands and complies with the medication regimen. Okay, we're moving fast. I in our ADPI, implementation. Okay. First of all, we want to promote an optimal response therapy. That's kind of like our goal, right? So what kind of interventions are we going to be doing in the implementation phase to support that goal? We're going to be watching them for adverse reactions and telling the doctor. We're going to be doing administration of our medication if ordered that way, if that's the route. And with that, we want to monitor, record, and develop a plan for rotating those injection sites because we don't want to cause tissue damage in the same spot over and over and over again because we can have breakdown. And then if we're giving it IV, we want to be looking at that needle site, checking the rate of the infusion, and really looking at the vein to make sure that there's not irritation. Okay, so we're going to pause for just a second and we're going to look at, oh, did I skip? Oh, let's go back real quick. I'm sorry, guys. Monitoring and managing our patient's needs. We're going to be looking for diarrhea. We're going to be checking and recording the color and consistency of each stool so we know if our patient is starting to develop C. diff. And then acute pain at the injection site. We want to inform the patient that it might burn or sting and to let us know if it's really bad. And we need to be flushing that line. Okay, here we go. Now we're on to question 2. Is the following statement true or false? Frequent liquid stools may be an indication of superinfection or pseudomembranous colitis. And that is true. We're looking for that because we're worried about developing C. diff. And if we're going to develop it, we usually start to see those symptoms 4 to 10 days after we gave that initial fluoroquinolone administration. Okay, we're continuing the implementation process. So how will we accomplish the goal of educating our patient and family? We're going to explain why we have to take the drug at the same time and as ordered, right? We need to advise them how important it is to continue taking the medicine until they've done the entire treatment. Otherwise, we create superbugs, right? And we need to explain the necessity of contacting the doctor immediately if they develop adverse reactions. Monitoring and managing our patient's needs. So in regard to acute pain related to tissue injury, we need to be looking at that needle site, the rate of infusion, and we already talked about looking at that vein for tenderness, pain, and redness, signs of inflammation. And diarrhea. Okay, educating our patient and family. They need to know what the adverse reactions are so they can be looking for them. And then we need to tell them, especially with those more serious complications, what they need to report to the doctor. Okay. And then developing a teaching plan would be a really great opportunity to educate the family and actually incorporate them in that teaching plan information. And it might have information about what they need to do when they go home and how to take care of their loved one or themselves once they get there. Evaluation, the final step of our ADPI. We've achieved our therapeutic effect. Our medication is doing what it's supposed to do. Yes. Infection is controlled. We got it under control. The bowel has been cleansed sufficiently if we're going to have surgery, because we want to kill all those buggy bugs before surgery, right? And then my patient's fluid intake and outtake is appropriate, intake and output is appropriate. These are positive results of the during the evaluation, right? These would be great things. Adverse reactions would be identified, reported, mitigated, and managed, right? We saw them if they showed up, we told the doctor, and we handled them. Patient and the family understand and are compliant with the drug regimen. Very important. Okay, so yay, we completed our nursing process. We did all of our interventions and nursing responsibilities throughout the assessment, diagnoses, planning, implementation, and evaluation stages. And now we've got a question to test our knowledge. Is this statement true or false? When medications are given IV, the vein needs to be monitored frequently because medications can be irritating to the tissue. True or false? That's true. We talked about it multiple times, right? We have, if it's IM, it can cause irritation in the tissues, obviously like the muscle layers that we're injecting it into, and we need to rotate those sites. And if it's being given IV, like this question talks about, we need to look at the vein and the insertion site of my IV for redness, tenderness, and some swelling. Okay, well, great job, guys. We talked about fluoroquinolones. We got to know them as a DNA synthesis interrupters, right, for bacterial infections. And you guys did a really, really great job answering the questions. I'm sure I'm going to give you the benefit of the doubt. And just make sure that you go back in there and really look at each part of the nursing process and what our nursing responsibilities are, how fluoroquinolones work, and what kind of examples of drugs that fluoroquinolones we have or we presented in the lecture today. And if you have any questions, reach out to me and I'd be happy to help you. I'm going to end this presentation and jump into chapter 10.